Hi, I'm Beth. I'm part of Reverse Rett and co-hosting today with Rachel, who I think will join us a bit later. So thank you for joining us. We are delighted to have Dr. Rebecca Winderman joining us today all the way from LA. And particularly apt, I think, that she's joining us today, the day before Rett Syndrome Awareness Month starts here in the UK. And talking about an issue which I know affects a lot of families' daily lives. So I think that's particularly apt that she's talking to us today. Before we get going, usual bits of housekeeping. As I've said, if you can flick your camera on for a second, just so we know who you are, but I think everyone's done that now, so that's great. Please keep muted during the presentation, just so we don't get background noise. Please note the session is being recorded and will be posted onto our YouTube channel after, so that more people can access the presentation. And as we go along, Dr. Winderman is happy for you to interrupt if you have a burning question, but also you've got the chat box that you can type your questions in that we will then put to Rebecca at the end, or you can wait till the end and raise your own hand and ask your question directly, which is probably even more effective. So quick introduction to Dr. Winderman before we get going. As you'll have seen when you booked your ticket, she is a pediatric gastroenterologist at Jamaica Hospital in New York, with extensive hands-on experience treating neurologically complex children with a wide range of gastrointestinal issues, many of which I know lots of families here are grappling with in their daily lives. So I think it will be a very valuable session for all of us. Dr. Winderman is really well known in her field for an integrated approach to medicine, with a focus on nutrition and lifestyle, and is self-confessed, I believe, microbiome obsessed. So I'm interested to hear what that really means. She's also known, interestingly, as the dancing poop doc. Some of you may have discovered her YouTube channel already. It's well worth a watch. She combines informative messages about gastrointestinal issues with music and dance routines. It's very entertaining and very informative. We're very lucky to have a personal connection to Dr. Winderman through Hazel, who is on the call, who is our colleague and fellow Rett grandmother. So without further ado, I will hand over to Dr. Winderman, who's joining us despite the time difference. And thank you in advance for what is about to come.
You're very welcome. Hi, that was such a lovely introduction. Thank you so much, Beth, and thank you, Hazel, for having me. It's nice to meet all of you guys. And while I'd like to say it's very, very early, I'm actually in New York and it's not so early, but I would get up earlier if I were in California. So don't let that fool you. Okay, so I'll just jump right in here. I think it's probably the easiest way to get on with this. All right, can you guys see my screen? Is this, I feel like everyone asks that, but I know that you can, so there's that. Beth, everything good? Good? Good, all right, cool. Okay, so let's talk about Rett syndrome and the gastrointestinal tract, common issues faced by girls with Rett. I will just quickly, what will I do? Nothing. All right, so you did a great introduction of who I am, double board certified pediatric gastroenterologist and hepatologist. That's a fancy way of saying I'm also a liver doctor. I'm currently practicing in New York City. I'm the director of the Department of Pediatric GI at Jamaica and Flushing. I went to Brandeis for undergrad. Probably none of this makes sense to you guys, but anyhow, all in all said, I'm here because I'm dating Hazel's son, and she's very resourceful. So you can thank her for that. And I'm actually really glad to be here and very honored. And I didn't know about your program or foundation, and now I do. And so I'm happy to promote awareness about it as well. All right, I have a shameless plug for you. Like Beth said, I am on social media, and I would really, really, really appreciate if you followed me. My name is Kids Gastrodoc. I don't know why it wasn't able to stay, but we can do that after. I have no relevant financial disclosures, but I'm certainly opening to establishing them. So if anyone has any sort of connection anywhere and would like to plug me in there, I'm happy to be financially associated. Objectives. So I'd like to educate you and hopefully keep you somewhat entertained during this presentation as well. Okay, so here's what we'll go over today. So we're going to be able, hopefully by the end of this, to recognize some problems potentially related to the gastrointestinal tract, also GI tract. So you'll hear me say that a lot in Rett syndrome. We'll recognize quote unquote red flags or signs that you'll need to call your physician. I want you to understand the rationale for GI testing and understand how we approach treatment of GI function or dysfunction in Rett syndrome. And then I'd like to discuss the role of microbiome, the latest research, and the role of diet. And then afterwards, we'll have a nice Q&A session as well. All right. Like this is not working. Okay. Okay, so GI tract involvement in Rett syndrome. So how common is it really? Glad you asked. Overall, GI dysmotility or dysfunction in the motility aspect of the gastrointestinal tract is pretty common. About 92% of girls with Rett syndrome have some sort of GI dysmotility. So, you know, either feeding difficulties in order of how common they are. So feeding difficulties, about 81%, constipation's a big one. I'm sure you guys have encountered. Chewing dysfunction, so kind of falls under feeding difficulty, bloating, issues swallowing, reflux is a big one, and delayed gastric emptying. I'm actually not going to talk about biliary tract disease or liver disease. It's very uncommon, and at this point, probably a liken to the general risk in general population. So I won't touch on that today. So let's talk about feeding. We'll go from top to bottom. That's usually how I do it with my students as well. So when we talk about feeding, I want to cover chewing, swallowing, and nutritional requirements. So when we talk about chewing and swallowing, I guess we don't usually think about how complex it really is to coordinate mastication or chewing and swallowing. But there are quite a lot of muscles and reflexes and nerves involved in taking a bolus of food, chewing it, and then, delivering it back into the feeding tube or esophagus. So when we talk about issues with that, we talk about, we talk about poor mastication or chewing. We talk about poor tongue lateralization, so being able to manipulate it within the mouth and then being able to push it back or propulse it back into the esophagus or feeding tube. And we talk about swallowing difficulties. Probably our most feared or dangerous complication is what we call aspiration, or taking when a liquid, instead of going back into the feeding tube, actually goes into our breathing tube or the trachea, which lies just, I don't know why I can't point for you, but it lies just in front of the esophagus there. So looking sideways from the left to the right, it's the trachea in front of the esophagus, or the breathing tube in front of the feeding tube. And so getting the breathing tube to close, the feeding tube to open, it creates, it's difficult to do at the very least. So why do we treat, or why do we look for chewing and swallowing difficulties? We want to control symptoms, certainly. Sometimes it comes to a point where it's like the energy, to feed and to chew is more than it is, for the patient to be able to get the nutritional calories, meaning they tire out and they end up becoming, refusing to feed. And then we want to prevent complications like malnutrition and what we call aspiration pneumonia. So that would be the entrance of liquids into the breathing tube or trachea and into the lungs, and that can cause pneumonia. Okay, so what are some red flag signs, symptoms that you might see when or encounter, and you should think about it being a feeding or chewing or swallowing problem? So feeding that's taking more than 30 minutes per meal, that means that it is expounding far more energy to eat than willing to exert. So coughing, choking, gagging with liquids and soft foods is something we should be looking out for as well. It means that some sort of, the gag reflex is there to protect our trachea or breathing tube. And so choking often or gagging often is that reflex telling, the body, wait a second, it's about to go into the breathing tube. So that's something to pay attention to as well. Feeding refusal, again, the effort in is more than the effort out. And weight loss, right? So poor weight gain. So we see this a lot in any neurologically involved child. This is not just your girls with Rett. It gets worse during adolescence. You get this decreased body fat or skin fold, growth failure, we define as a body mass index of less than 5%. And, a lot of times I hear this even in well children that come to me with poor weight gain, but they often tell me, my child's very active, or in this situation, repetitive movements, right? So it's unrelated to the energy expounded by a child or by your girls with Rett. So it's not that they're losing weight because they're, giving so much energy out due to repetitive movements, and it's not a malabsorption issue, right? So we have to rule out malabsorption in all this, meaning that, if we're feeding enough calories in, are we absorbing the nutrients from that as well? And most of the time, these girls have intact absorption from the GI tract. So it's, what I'm trying to say here is that it actually ends up being a feeding, chewing, and swallowing problem. Okay. So what's the rationale for diagnostic testing? So basically we want to just make sure that these girls are not actually aspirating or bringing liquids into their lungs that could cause pneumonia, right? So we do something called a swallowing function study, or you might hear it as a modified barium swallow, or you might hear it as a swallow study. But basically what it involves is you'll come into the hospital or an outpatient radiology center, and they'll give you barium basically in different forms. So barium is, the white stuff that you see that's lit up. We can see it in X-ray. And they'll give it to you in liquid form and in solid form, usually a puree, and then in a cracker. And what it is a series of X-rays that they'll take to watch this. You see this white stuff coming down into the, hopefully, esophagus, but you see this little tail end in the front. It's very frustrating that I can't show you this here. I'm going to show it to you like this. Okay, so you'll eat whatever it is here, and you see this white radio opaque or lit up area. So that is the barium itself. And here it's going nicely into the esophagus. It's avoiding the trachea. But what you can see is what we call microaspiration, and this is happening actually is coming out into the trachea or the breathing tube. So this patient is actually aspirating on a micro level. So probably this is a patient that hasn't yet developed what we call aspiration pneumonia, hasn't been hospitalized, but we certainly want to get these patients evaluated and diagnosed prior to having an episode of aspiration pneumonia, obviously. And so, that's why I say red flags, look out for those red flags of choking, exerting a lot of energy, getting tired out with feeds. Okay. So how do we approach feeding and swallowing difficulties? So unfortunately, there's limited strategies that we have to approach this. We do deploy OT or occupational therapy, speech therapy for oral skills. However, as you guys know, these girls and a lot of neurologically involved children do progress over time into, inability to use their oral motor skills, and usually require some sort of alternative feeding method. Whether that be oral formula supplementation. I don't know what it's, if you guys have Ensure, Pediasure, Kate Farms, I'm not sure what your formula is, but some sort of liquid enteral nutrition. And then, we also do use a lot of these girls, and a lot of neurologically involved children end up needing some sort of feeding tube. So NG tube would be a nasogastric tube, and that goes from the nose all the way down to the stomach. And that's really a short-term thing. You can't keep that in for more than a month. And so usually we'll end up putting a gastrostomy tube in children. And I'll tell you, it is a surgical procedure. I do perform them. It is, somewhat scary for people that are outside of the field, right? Getting a feeding tube is not something that, you like to see your child have, but overall, parents and caretakers are usually very relieved when this happens, because it gives them the ability to feed calories to meet nutritional requirements, but continue to use oral feeds as well, but they don't have the pressure of getting enough nutrition and calories in through the mouth. So what we'll end up doing is surgically placing a tube here. And then I'm not sure how many of you guys have girls with feeding tubes, but it allows for medication and these liquid nutrition supplements to go in as well. And some also suggest or recommend blended tube feeds, which is just blended food that can go through the tube. And we can talk about that if that's of interest later. But either way, meeting nutritional requirements is imperative for any kid, but also for children who are neurologically impaired. Okay, so when do I start considering putting a tube in these children? So if your BMI or body mass index is less than the 5th percentile and you've been progressively declining over 6 months, I certainly consider at that point we're not getting enough calories in. That's a pretty good indication for me. If you've been admitted to the hospital for an aspiration pneumonia, which is basically, when you put anything in your body that doesn't belong in your body, you risk infection, right? Because your immune system comes, it attacks whatever it is, and it causes inflammation. So when when a person aspirates or brings a liquid into their lungs, the immune system recognizes that as foreign and comes and attacks it, and you end up getting inflammation or pneumonia in the lungs. So if you've been admitted for that one episode, it takes usually for me to start having that conversation with parents. And believe it or not, I do get a lot of parental requests from neurologically involved children for, it's just, again, it's a relief. Their kids are refusing to feed, it's exhausting. And certainly medication, if it's in a liquid form, a lot of these girls with Rett have seizure disorders that require frequent medication administration, and getting that down can be difficult, especially if the child's aspirating. But I want to make it very clear that having a tube or feeding a tube in any way does not preclude giving food by mouth. In fact, I always encourage parents with neurologically involved children to continue to consistently give whatever is deemed safe consistency as much as tolerated, because, and you'll know the safe consistency based on what we call a modified barium swallow, where you get the liquid barium and you get the pureed barium, and then you get I think it's like a cracker or an egg with barium, but they'll tell you, your child is able to have purees or your child can only have, solids. So I do really, really encourage it, because at some point, what we've come to realize is it's sort of like use it or lose it kind of a thing. So once you stop using muscles, anyone stops losing muscles, you sort of lose the ability to interact or utilize those muscles later down the line. All right. Constipation. I'd say this is about 90% of my clinic, even with neurologically intact children as well. So you're not alone in this. And as many of you know, it's a very common problem amongst the general population. So, I consider it dysmotility or issues with motility at its finest. All right. Definition. It's one of those things that, you wouldn't think you'd have to define, but we will define it anyhow. So it's any kind of difficulty with defecation, causing some sort of discomfort and happening over a few weeks. So if you're having bowel movements less than 2 times per week, the stools are nice and hard, small pebble, or even large, like ball size, anything that would, people say, oh, but I do have a bowel movement like every 4 days and it's huge. It clogs the toilet even. And that is also considered constipation, right? In general, it is a generalized dysmotility issue when it comes to neurologically involved children. It can also be functional, right? So this dysmotility happening structural, we want to make sure that they don't have any kind of anal stenosis or blockage at the end. Neuromuscular, certainly. So issues with the nerves at the bottom of the rectum that tell the body when it is time to poop, to relax. And that's, Hirschsprung's disease is one of those diseases that falls into that category. We want to make sure they don't have any thyroid issues. And then, something also to consider and very commonly found is that there's drug-induced constipation, right? So a lot of these girls are on seizure medications and they do cause constipation. So it's something to consider as well. All right. So why should we treat constipation? Obviously control symptoms. You do have, it is painful. I mean, if any of you have been backed up, it's certainly painful. You have abdominal pain, rectal, anal pain. It's also quite nauseating. I've, believe it or not, seen children lose weight or not thrive because of being so chronically constipated. And then, we would talk about diarrhea, a lot of times just distinguishing whether or not that's what we call overflow incontinence. So meaning that the rectum is so full of stool that the new stool comes down, solids stay because of the plug of hard stool, and the liquid comes out. And so it looks like diarrhea, but really it's the result of being so impacted. And I would say that, for that, it's one of those things that you sort of have to pay attention to over a long period of time to see if that really is an issue. And from, my experience, the caregivers, you guys, family members are quite astute and know your children pretty well. So I often do take parents' words over my own assumptions in a lot of situations. So, and we want to prevent complications, right? Fissures or little tears in the rectum, impaction, like I said before. Encopresis is just the official word for that, diarrhea or overflow incontinence. And volvulus. So, if you become so impacted, you actually do risk the possibility of obstruction or blockage in the GI tract. And what ends up happening is that you lose blood circulation, and then, that part of the GI tract becomes dead, sort of, and you risk sepsis. Very rare, but certainly in children who are non-communicative, neurologically involved, we do have to pay close attention. They are not going to be able to tell you when this is an issue. And so, being on top of it is super important. So that is why I'm very vigilant about constipation. And if I'm honest with you, I would say 99% of my neurologically involved children are on some sort of constipation treatment regimen on a daily basis without hesitation. So very common, and not to be ashamed. All right. So again, what are some red flag signs, symptoms that you might be seeing? So, any change in consistency or frequency, I would say just be alert to that. Blood on the stool, not in the stool. So, when we talk about constipation, blood related to constipation, we talk about the reason being is because you're cutting, they're small cuts when the stool comes down. And so what you're getting is blood streaked around the stool. And then oftentimes when you wipe. When you talk about blood in or, mixed into the stool, I would say that's probably not constipation, but also something you need to be talking to your doctor about. Abdominal distension is common in a lot of these conditions, discomfort or pain. Urinary tract infection is something that we don't talk enough about being a consequence of constipation. And that is just because the bladder lies right on top of the colon or rectal area. And so when you have so much stool in that area, you press up against the bladder. And so you end up having urine that's retained in the bladder. And that is a nice nidus for infection or source of infection. And so a lot of times, I'll see that, patient was treated in the ER recently for UTI. And I see that encounter, in my chart for them. And I often ask about that, and that can give me a clue also, because, to be honest with you, in women, especially, neurologically involved women, UTIs should not really be happening at a young age like this. So that's something to consider. And then of course, any sort of feeding refusal, vomiting, that's something that is a red flag for anything. So I would definitely consider that a reason to reach out to your physician as well. Okay, so how do we diagnose it? I'd probably say my biggest pet peeve is when the ER calls me and tells me they got an x-ray on a kid they thought might have constipation. There is no reason to irradiate children who you think or might have constipation. Treatment is very benign, and I'd rather honestly treat it rather than irradiating children. So medical history is good enough. An exam is good enough. And, in general, when we talk about long-term constipation, issues with constipation, certainly a workup is somewhat, you might want to think about a workup just to rule out certain things like thyroid issues, celiac disease. Nobody needs to stick their finger in the rectum. That is not necessary nor recommended anymore by our guidelines. And then some of our imaging studies you might consider if they're long-term chronic constipation, especially neurologically involved children, refractory to sort of your initial or first line medications or treatments for constipation would be looking at how long does it take the stool to exit the colon. So various methods of looking at that. SITS marker study. So basically, again, swallowing contrast. You get a lot of swallowing contrast going on in the GI tract workup, which is, I've just realized doing this presentation, so something to consider. X-ray or MRI, it's very, very uncommon to have to do this. A barium enema. So basically that would be to rule out something called Hirschsprung's disease, which is an issue with the nerves at the bottom of the rectum. If your child stooled or had a poop within the first 24 hours of life, 99% chance that Hirschsprung's is not an issue. So I would say that's little of no value. But if that is not the case, your child did take some time to poop after they were born, that's something that should be brought up and definitely worked up. Manometry, again, is basically you blow a balloon up in the rectum, and then you see how hard they're able to push. And then, endoscopy, colonoscopy, I'd say 0.01% of patients need it. And that's most likely just to evaluate for other inflammatory conditions. But again, I don't like to give patients like 39 different diagnoses. We can probably assume that patients who are neurologically involved are likely having some sort of dysmotility associated with neurologic degeneration. So there's that. All right, this is good for everyone. Let me just tell you, wake up if you're awake, if you're sleeping, because anyone who has constipation, I get asked these questions all the time. So let's talk about the different over-the-counter treatments for constipation. You go down that aisle at your drugstore, and it can be quite confusing. So we'll just review it here. So there are 4 different types of over-the-counter treatments for constipation. Some of them are safe for long-term use and others are not. So lubricants, what we call lubricants, are some, what they're basically kind of like, they are lubricants. Basically, they make the area around the stool soft so that the stool can exit. So this is mineral oil enemas. You basically shoot oil up your bum, and obviously that can be helpful to lubricate the stool out. So that's pretty fast acting. I would probably say is not 6 to 8 hours. You'd probably be good after a few hours. And then you have osmotic agents. So those are agents that will pull water into the rectum or colon. And those are agents that you're going to need to make sure that your child drinks a lot of water or is fully hydrated, right? Because it's going to take water and prioritize it into the colon. Whereas in other instances, if you didn't have that, your body's going to allocate water to, well, more essential organs, but I would argue that that's not the case. That your GI tract is quite essential. So this is I don't know about what they're called in the UK, but this is, anything with magnesium hydroxide. In the States, it's called Phillips milk of magnesia, mag citrate, polyethylene glycol, Miralax, Restoralax. And these come in enemas, suppositories, liquids, and it's pretty quick, 30 minutes or less. And the osmotic agents in general are usually the ones that are safest for long-term usage. And then you have the stimulant laxatives. So that's your bisacodyl, Dulcolax, Senecide, Senecot. Those are ones that are actually going to stimulate your GI tract to contract and get rid of stool. They come in all sorts of forms. They're also pretty short acting as well. And those are, I would say, probably least safest for long-term use because of the risk of dependency, meaning you can sort of depend on them if you take them for too long in order to poop. But more recent literature suggests that if you need them, it's better to use them rather than not stool at all. So I do have patients that are on stimulant laxatives on a daily basis for quite some time, and it's been I've been quite successful with that. And then you have your general stool softeners with sort of just retain water that is already in the GI tract to try to soften it. I don't find them to be as effective, but they take a long time, and I wouldn't recommend it. It's probably the least effective out of all of these, but you can use them long term. And then I would just give you a word of caution to beware of herbal remedies. A lot of hype, very little science, and not regulated, at least in the States, by our Food and Drug Administration. So I've seen a lot of patients, I've admitted patients with on herbal supplements that have, and this is in general for herbal supplements, with many side effects ranging from very serious to very mild as a result of herbal preparations. And then, when this is not enough, and, I would say the most important is to recognize that need to escalate therapy and to sort of, it's a level of humility and just acceptance that, hey, this is not working for my child, despite raising dosage, despite changing class of over-the-counter medication. And that's okay, because again, getting your child or patient to stool or to have regular bowel movements is so important, especially for neurologically involved children who already have motility issues. So they're not, many of the kids that I see and treat are, cerebral palsy children, are wheelchair bound. They don't have the luxury of being able to get up and move around, which can also be pretty helpful. Although I have patients that are quite mobile that end up on these drugs as well. So no shame in that game. So I don't know if these are available in the UK, so I'll go over them really quickly. But basically they come in, I would say, 3 different categories. So the 2 yellow ones basically regulate fluid secretion and motility. So they actually, they act on the channels, the electrolyte channels in the lining of the GI tract, and they actually stimulate water to come in. And at the same time, they also stimulate motility, so contraction and bringing water in. They're rather fast acting. And then, lubiprostone or amitiza basically is without the motility agent, and it just increases fluid in there. The other 3 are really opioid induced. I don't know how common it is. I know a lot of these Rett girls have a lot of pain syndromes, but just keeping that in mind, that opioids or pain medications in general are highly known to cause constipation. So these 3 drugs at the bottom are ones that block the opioid receptors or the pain receptors in the GI tract, so that any drug cannot bind. The drugs that we use to treat pain syndromes don't bind to those receptors in the GI tract and cause dysmotility or constipation. So those are those. And then another thing to keep in mind is that, at least in the US, these drugs that are prescription drugs for constipation are really only approved for children over 18 years of age. So unfortunately, I don't get to use this, but I will say that most medications, all medications are first approved for adults. And then I would say 3-4 years later, they end up being approved for children as well, just the way that our clinical trials work in the US. Sure, they work that way too. And then, ultimately, I do have a lot of patients that end up needing surgical treatments for constipation. And this is mainly in my neurologically involved children. This is something that also somewhat of a relief to parents and caregivers, as odd as that may sound. So what we end up doing is putting a tube, it's a surgical, almost like a placement of a gastrostomy tube, a button, but it goes actually at the lower part of where the colon meets the small intestine. And the idea here is, when you think about an enema, right? When we give enemas or liquid, we give them what we call retrograde. So we shoot them up the bum, right? And they can make it probably all the way over here to the flexure over here. And that's pretty much about it, right? But when we talk about kids with chronic dysmotility, neurologically involved children, a lot of the times motility issues happen really starting from the very beginning of the colonic tract. And so putting a tube there allows for what we call anterograde enemas. So, it really shoots water or stimulant through the GI tract at an earlier point. And so, many times, again, it's a scary thing to think about, but with kids with chronic motility issues, this can be quite the relief. And I say this all the time: the only people that enjoy enemas are the ones that need them. The only people that enjoy, surgical anterograde enemas are the ones that need them. So, that is a consideration and something to think about. And gastroenterologists also do place these as well. It's a surgical procedure. All right. Constipation. Okay, so ultimately, we really want to make sure that we avoid what we call gastrointestinal crisis. So again, basically, this is just avoiding obstruction or blockage, right? You have enough time where the stool sits in the GI tract and it ends up being, what we call impacted here, right? And, stretch something enough and you will have sort of a tear or what we call perforation. And, the GI tract is awesome. Well, I'm partial to that, but, it's a great organ. It gets rid of a lot of our waste, but, it being contained in the colon is an important caveat to that, because, introducing any fecal matter into our body that's not contained in the colon can cause what we call sepsis or infection, as you can imagine. Being so certain things that sort of lead to that, obviously you don't need to know really about this, but intussusception is sort of the sliding we call I call it what's it called, it just slides in and out like this. And then you get malrotation. So it's like a twisting. Eventually it's trying to really get the stool out. So it'll slide in and out, and then it'll try to twist on itself to move it down. And then, eventually you'll get such twisting that it'll cut off blood supply. And then eventually it will perforate or make a hole. So, considerations for that, obviously, your children who have perforation are quite ill appearing, they're unstable, they have fever. So, this is going to be quite clear to you. And that's the reason why we treat this earlier on. And again, no shame in the game. If something's not working, we're here to help you make the next step or adjust, whatever treatment you're on. Just a myth here that I see a lot being toyed around with is the idea of air swallowing. So many neurologically involved children do swallow a lot of air, and that's sometimes why you'll see such bloating occurring, but air swallowing alone does not cause intestinal perforation. So, that we'll just clear the air on that. And then just also know that, so a lot of these things are really not unique to Rett syndrome. The intussusception, so sliding, twisting, all of this stuff can happen in neurologically intact children and does happen. So I would say the risk of this happening in a Rett syndrome patient is probably equal to the risk of it happening in the general population. So not to worry. However, when you're dealing with neurologically involved children who either aren't able to communicate or don't communicate effectively, it's sort of what I call veterinary medicine in a way, right? I consider pediatrics to be veterinary medicine in general. At a certain age, they can talk to you, but for the most part, you're sort of evaluating them and using your eyes, your ears, to sort of figure out what's going on versus, being obviously not able to tell you. So that's the only thing I would say, only caveat you should think about. Okay, everyone's good. We're good. Everyone's thumbs up. Yeah, we're good. Thumbs up. I like thumbs up. That's good. All right. Reflux, and I say gastrointestinal and not esophageal because I think that we don't think about enough kids with motility issues. It doesn't just happen from the esophagus to the stomach, but it also happens at other junctures as well, where you get sort of backwash of substances in the GI tract coming the wrong direction. So let's talk about reflux. Who's excited for that? This is good for everyone, I'm not gonna lie. You guys are going to be experts in the GI tract soon. I'm going to be out of a job soon. Anyhow, what is gastroesophageal reflux? So that's just the reflux of anything that's in your stomach back up through your esophagus. I would say kids with, motility issues, neurologically involved children, sort of have this persistence of reflux beyond infancy because of, when you think about any kid, or when I explain it as a baby, they're establishing muscle coordination, right? Their hands and their arms are flying everywhere. And the same is true, really. It's a muscle that sphincter that sort of connects the feeding tube to the stomach. It's in the same situation, right? It's developing, it's strengthening. So if you have any muscular issues, outside of your body, or any issues, in that regard, musculoskeletal or any neurodegenerative disease, you are going to have the same sort of thing happening on the inside to muscles on the inside. And the esophageal, lower esophageal sphincter is in the same category. So that's coming, allowing substance to come up into the esophagus. And, you may or may not know, but there's acid in your stomach to help digest. And there's digestive enzymes and bile, all stuff that can sort of be caustic or irritating to your esophagus. Many people have this, not just Rett patients, as you know. So I just want to bring that into perspective for you. Diet is a huge one. I'd say, 80 to 90% of neurologically intact individuals who have reflux can be monitored and controlled with dietary and lifestyle changes. Genetics, I mean, if you have reflux, it's quite possible that you will pass that on to your children. Obviously, structural, hormonal, we don't talk about that. Neurologically, environmental, I'm not going to go over that. Okay, why should we why treat reflux? So you really want to control the symptoms, right? It's uncomfortable. So I would say, in kids, that a lot of my cerebral palsy children who are wheelchair bound, what you'll see them when they're feeding, they're sort of arching their back, and it looks, uncomfortable because they're feeling that acid come in. And then, what you can see a lot of times is this looking like they're sort of like having a bad taste in their mouth. And you may even hear, a little bit of wheezing from that fluid coming up, or noisy breathing, I would say. And so you really want to prevent complications is really what all this is, right? So any sort of thing, acid or whatever coming up is an irritant, right? You can get ulcers at that junction there, and ulcers or inflammation eventually lead to narrowing, right? Because your body's going to sort of attack that area, and then it becomes inflamed, and that can lead to narrowing. And then, when we talk about, obviously aspiration pneumonia, it doesn't just come from above, right? When we eat, that's one way it can go into the trachea, but you can have stomach contents come all the way up to the mouth, right? And then you breathe them back into your breathing tube or your trachea, and that can go down to your lungs and cause pneumonia as well, or inflammation as well. So and then I would say lastly, and this is true for the general population, not just for Rett's patients, but you want to control reflux or acid in the esophagus or the feeding tube because of a long-term complication called Barrett's esophagus. And that happens with, it basically so much inflammation that it actually changes the lining of the esophagus. So it turns over. If you have so much cell turnover, right, that's where you get an increased risk of cancer in any part of your body, right? So inflame something enough, if you're a smoker, you inflame your lungs enough, that the idea is rapid cell turnover to try to heal that. And then it's just uncontrolled turnover at that point. So we want to make sure that we treat for those reasons as well. Okay, so how do I know when patients have reflux? So there's, obviously, irritability, screaming. You can get this nighttime awakening where, again, you see these arching of the back. In patients that are nonverbal, a lot of times it'll be new onset of self-destructive behavior, biting arms, banging head. I see that a lot in my neurologically intact, patient or neurologically involved patients. And then, vomiting, regurgitation, burping, feeding refusal, wheezing, aspiration. I consider those non-specific signs, but I will tell you this much. When I look in the back of the mouth of any patient that has reflux, you may see these little white, hyper white markings on the teeth. And that is a pretty good indication for me that there is acid coming up or reflux, right? Because this is basically acid will break down enamel, right? So you can see that also happening in the back by looking at the back of the teeth. And many of you are probably looking in the mirror now, but a good thing when I see these patients is I tell them, next time you go to the dentist, ask them to bond the teeth. It's basically a substance that they put on a Q-tip and they wrap it around, or they swipe it all over the teeth. It's not as intense as bonding the teeth. I never knew what it was until I looked it up. But so I would say that, and then obviously we treat and we use medications to treat this in order to prevent further degeneration as well of tooth enamel. Okay, everyone's good. We're good. You still like me? Okay, good. All right. So diagnostic testing, also something I super hate. In on the average patient, we don't put you through x-rays. We don't irradiate you or put probes down you, right? Because we'll just rather give you a medication, see if it gets better, right? But for kids who are neurologically involved, again, same thing. We may do an upper GI series, same thing we talked about before. You swallow some radioactive material, lots of radioactive material talk here, and I'm going to consider this going forward. But that's really the crux of it is I just treat. But again, if there's any question of aspiration, so you can actually see here. So this is what it looks like. So you start eating something, it's a series of x-rays. We use the x-ray machine and we watch it actually go down the GI tract. You can actually watch swallowing happen, as you see here, progressively. And then we take an x-ray of the chest at the end. And as you can see here, I mean, this is a very profound example, but just to show you, this is in the lungs here. You don't want to see contrast in the lungs. So this would be an indication for a tube to be placed. So again, reflux can happen from above. It can also happen from below. There's pH probing, which is basically a probe you place down the nose, blah, 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 it records the number of events and duration, whatever. I don't use that. We don't recommend it, but it is something that, people do use in other places. So that may be something you might run into. Manometry is basically you put an endoscope down or a tube down, you place sensors along the lining of the esophagus just to see, and it'll show you contractions, how the motility is doing there. I don't use it when there's question of reflux, maybe a question of feeding disorder. Yeah. Upper endoscopy, I never do for if I'm concerned about reflux. Gastric emptying scans are an interesting thing, and it's something that has become very popular. A talk of something called gastroparesis, or late emptying of stomach contents into the rest of the GI tract. So that's become pretty popular recently, but I would say that the emptying scan is basically just watching contrast, taking x-rays every hour, 2 hours, and then again 8 hours later to see how much of the contrast has actually left the stomach. There's no normal value range for children under 18. So I consider it, and our society considers it, to be a pretty useless test, but it may be something you may run into at a later point. So I wanted to cover that for you. All right, wake up. We're going to talk about reflux meds. This is a big story. You ready? Okay. Like I said, kids or patients who are neurologically intact, we can deal with dietary changes. So cut out the spicy foods, caffeine. By the way, chocolate has caffeine, so that needs to be cut out as well. Citrusy foods. And then I would say in general, watching out for these quote unquote trigger foods. And those are individual to you or your children. So when people come to me and parents will say, every time he eats dairy, should he eliminate dairy? Because every time he eats dairy, he has diarrhea or vomit. It's like, if you've identified a food that is a trigger for whatever purpose, if the eczema gets worse, if you have diarrhea, then like my blessing to you is go forth and eliminate it. There's no reason to continue to eat something that for you is causing you symptoms. Positioning, so keeping, a lot of this is infant stuff, but for neurologically involved children, also something to think about is keeping them upright for 30 minutes after eating, and you can elevate the head of the bed for 45 degrees or just a little bit. I would say get one of those wedges that goes under the mattress, please. I've had a lot of, unfortunately, a lot of patient experience where, suffocation occurs because, parents are like, oh, well, I put a pillow underneath them, right? And babies or anyone really move around and can suffocate from that. So medications. Okay, fun. So this is a chart of all the medications that are over the counter, prescription. I don't know how they are in the UK, but we'll just quickly go up. It's a stepwise approach, and I'm going to clarify all of this for you, and you're going to be experts, and you'll never spend another dime on any medication that is a medication that's not a generic name. So generic medications are just as good as any name brand medication. So when we talk about first line therapy, we talk about antacids. So just basically they're your Tums, any sort of Mylanta, they line the stomach, they bind to the acid and whatever acid's in there, and it's quick, it happens immediately. And then, you get to, okay, well, I'm throwing down Tums every 20 minutes, not sustainable. And you have to step up to what we call H2 blockers. So these block the body's signal to the stomach to produce acid. And these are your ranitidine, cimetidine, which are Zantac, Tagamet, but anything with ranitidine or cimetidine, famotidine, you can use those. So that'll be your CVS brand, or I don't know what you have, but your drugstore brand is perfectly fine. They work just as well. And when you have continued symptoms, so you're taking, ranitidine or famotidine every day, and you're still having sort of what we call breakthrough episodes of reflux, then we move on to what we call proton pump inhibitors, our strongest over-the-counter medication for reflux. And these actually block the secretion of acid into the stomach. So they bind to the pump that pumps out, acid. And these are your Nexium, Prilosec, anything with so omeprazole, esomeprazole, pantoprazole, those are just as good as your Prilosec, Nexium. Don't worry about getting the brand name. There's literally no difference. So you're fine. And then, thinking about, long-term usage, gosh, there's been so much put out about this, and so much contraindicating research and data. Every other day they're coming out with a study that PPIs cause, long-term PPI usage, increase your risk for prostate cancer, increase your risk for this, increase your risk for that, are fine or not fine or okay. Any medication over a long period of time will come with some sort of side effects and complications. Overall, the general consensus based on literature to date does not suggest that long-term usage of PPI specifically it puts you at an increased risk for any sort of long-term chronic disease or morbidity or mortality. So sit safe with that idea. I want to also just bring up the fact that, how are we doing on time? We're not. Okay, so just want to bring up the fact quickly that, antacids or any sort of acid reflux medications will not stop the number of events of reflux coming up. So if your child's vomiting from it or, having wheezing or aspiration, the only thing that these drugs are doing are neutralizing the acid or stopping acid production, which will, obviously you still have liquid coming up is what I'm trying to say here. Okay. Prokinetics are the next level. So these are medications that sort of move stuff out of your stomach down further down the GI tract, so they don't sit there long enough to come up. And then, a lot of kids that I treat do end up needing surgical intervention. So what we call a fundoplication, where basically I'll take a part of the stomach and wrap it around the first part of the esophagus or feeding tube, so that less ability to have liquids here you can see. So it sort of tightens that junction. Unfortunately, many a time, I'd say 80% of the time, they do need to come in again. After a few years, these do slip off. So it's not an end all say all. Let's just see where we are. Sorry. Gas and bloating, I would say probably, we'll just quickly go through this. I don't even know where I am in my presentation. I just talk. Is that what it is? Oh, we're almost done. This is exciting. All right. So the most fun part is at the end, but we'll get there. All right. Gas and bloating. Number one cause is constipation. But basically, I can't tell you the number of times I get these pictures. The kids come in or parents come in and they show me these pictures of them looking completely pregnant and then having a poop, and they look, they've lost 10 pounds. Yes, these are common. Yes, this is normal. That's why getting them to poop on a regular basis is so important. Okay. So, air swallowing is another one, but we treat because due to the fact that, it's uncomfortable and, eventually, and, you can have some perforation or hole that's created if you stretch enough. It's very uncommon. Obviously you'll see this, right? You'll see a nice big belly, what we call a tympanic belly. So if you actually take a finger and you place it on the abdomen, and then you take another finger and you tap on top of that finger, you'll hear air or a lighter sound. So you can try that throughout your body, and you'll see when it's full of something, it makes a dull sound versus when it's just gas. And you end up being a doctor, basically. You don't need a lot of testing for this, but SIBO, or small intestinal bacterial overgrowth, has become a very hot topic recently. They do sell these little at-home SIBO tests. SIBO is basically, the idea is that the bacteria or microbes, there are many of them in your GI tract, and basically they go from only a little when it comes to the stomach, or none in the stomach, and then as you progress down the small intestines and into the colon, they become progressively more, and that's normal, right? So the idea though of SIBO is that you have too much bacteria in the small intestines than you're supposed to, and those produce gas and blah blah blah. In any event, these tests are pretty easy. You can do them. The treatment ends up being antibiotics. It's not my favorite, and I usually don't treat, but the idea is that you swallow sugar, basically sugar goes down, it gets absorbed, goes into your lungs, blah, blah, blah. You breathe through a tube, you send it to your doctor. They'll probably tell you they have something. Everything is a money-making machine. In any event, most of you should eliminate lactose. Well, I speak in terms of North America. 87% of North Americans are lactose intolerant. So oftentimes removing cow's milk from your diet can improve symptoms of many things. And those of you with a gastrostomy tube are very lucky. You can vent air out of the tube. So that's something you have over the rest of us. So, just taking that syringe, and attaching it to the tube and taking out some air, it can be very, very helpful. There's lots of different medications, gripe water, simethicone. Try it. There's nothing wrong with it. I would avoid using antibiotics unless you have documented SIBO or you've had that test. And then I just address the constipation. Like, that's usually the cause of it in neurologically intact and neurologically involved children. And that's it. All right. My favorite part, wake up. This is exciting. Microbiome, get pumped. All right. Well, I'll give a brief overview of what the gut microbiome is. And then, no, I won't. Okay. It's out of order, but that's fine. I'm a pro. Okay. Gut microbiome. So gut microbiome is basically, you consider them a community, and there are trillions of them, of microbes, and that includes bacteria, fungi, archaea, that live in your colon. And basically, even though they live in your GI tract, research now has come out that they actually control a lot of what happens in your body. And so we've identified what we call, and I'm going to actually call it, most of them are bacteria. So if I use the word bacteria, please just note that there are also fungi, archaea, and many other kinds of microbes, but the majority of them are bacteria. But you have these good bacteria and bad bacteria. So we've identified certain bacteria that reside in your colon that are associated with good health outcomes, longevity, and then bad microbes. We know that certain microbes that are, associated with cancers, with heart disease, with diabetes, depression, anxiety, Parkinson's, many, many diseases. In the last 10 years, it has exploded as a research topic. And then the idea being, there are many factors that can influence your gut microbiome, including, but the most prominent one being diet, right? So the idea of dietary changes is to sort of feed the good bacteria and starve out the bad bacteria. And we can talk more about that at a later time if you'd like. But that's the exciting part about the gut microbiome. And then in particular, when it comes to Rett syndrome, they've actually, a recent study actually has identified that the gene, the MECP2 gene that is involved in Rett syndrome is not only found in CNS, but there are receptors also in the GI tract, specifically in what we call the enteric nervous system. So you have the central nervous system controlling most of the body, right? But you also have what we call the second brain, and it's a nervous system that goes throughout your GI tract, and it functions all on its own. So, the idea of all these GI issues, dysmotility, and even I would say the opposite, and we'll talk about the gut-brain interaction, but the idea that this gene is also in the GI tract is something that is a consideration and an interesting point in terms of maybe a target for treatment, and also introduces a role for diet in treatment, which is, I'm biased, and this is selection bias. I definitely look for treatments that are dietary or gut microbiome specific. So we can go through why I think that this might be an interesting thing to look at. And it's not just me, it's the scientific community as well. But the idea of the gut-brain axis, which we have established to be basically a truth at this point. So what we know is that the bacteria that reside in the colon, right, the gut microbiome, that communicates with the brain and what we call the gut-brain axis. And it's not just the microbes that communicate with the brain, but also the brain that communicate with the microbes. And by the microbes, I don't mean the actual microbes actually go into the circulation to the brain. No, I mean the substances that the microbes make, and what substances they make depend on, number one, what kind of microbes they are, and number two, what we're feeding those microbes, right? So when we feed them the right things, what we call prebiotics or fiber, we end up getting substances that promote health, promote the production of good bacteria, and the bad bacteria that are in there basically are starved out. Okay, so they don't get to produce cytokines, hormones, all these different sort of serotonin, things that go to the brain, and vice versa, right? Things that are produced in the brain also come down and affect the way that the GI tract functions, and the things that are blocking things that are produced, promoting things that are produced by these microbes. Okay, so the idea is that now we've sort of established, having established that access, that bi-directional talking to one another, we now know that the gut microbiome is involved in pretty much every systemic disease or health state, right? All the way from the brain to the GI tract. So that's a breakthrough that we've made over the past 10 years. So the research, though, also suggests that alterations in the gut microbiome in girls with Rett syndrome may underlie the varying degrees of clinical presentation. Okay, so that's a key thing. So how shift in microbiome, how I would say the alterations or the differences in the microbes within girls with Rett syndrome, we've identified certain microbes, and the number of microbes, abundance of microbes, and diversity of microbes may actually predict the severity, long-term severity of outcome in these girls, right? So I'll explain this, which is a very cool study that just came out. Okay, so this was a while ago, but this is basically, they took a bunch of girls with Rett syndrome and they characterized their gut microbiome, right? And what they found is the controls actually happened to be siblings, so that they were able to control for a lot of different factors, right? Environments controlled for, they grew up in the same place, for the most part, same diet. So gut microbiome in girls with Rett syndrome is markedly different than unaffected girls. Okay, so I want just take a look here at the different colors. Okay, so this one, when you look at the different colors, those are the different microbes, and then the size of the bars are actually the abundance of microbes. It's a little difficult here to see, but the overall idea, and I'm going to show you another chart that'll be very obvious to you, is that the result was that they found there's less diversity and an increase in shift of microbes towards more inflammatory microbes, right? So what we call, instead of having a nice community of good and bad microbes, girls with Rett syndrome were found to have more microbes that were considered bad microbes. Okay, so, and that shift is something we call dysbiosis. We really want harmony, symbiosis in our GI tract, and so that was found. I'm almost done. Just stick with me, guys. I know that I've been chatting for a while. I have like bring you 4 more slides. Okay. So, so this becomes very, very obvious then, right? So this is here, sorry. So these are the Rett girls here, and this is the control group. Okay. But forget the abundance, right? So this is at the phylum level. So this is at the you know, big level. When we talk about, you know, diversity, right? You can see that controls have a more diverse microbiome than girls with Rett syndrome. They have less diverse, okay? And why does that becomes important? Why? Because what they found was that the diversity actually predicted how severe the outcome or the progression of Rett syndrome was going to be. So the degree of decreased diversity directly correlated with what we call disease phenotype. So the more clinically severe patients, the girls who had it the worst, showed lower microbial diversity. So they had the diversity or the abundance of different kinds of microbes. You really want a diverse community of microbes that has been shown to be associated with long-term health. Those were decreased in abundance in girls with Rett. So, so purple here, you can see that these are the more severe presentations, girls with the severe Rett syndrome, and the blue up here are healthy controls. Right. And then you see orange here is like more mild and red intermediate. But you can clearly see a difference between the microbes that are in girls with very severe disease versus girls with who are not affected by Rett syndrome. All right. And then I think I might be, are we done? No. So then here comes my favorite part, is the idea of how can our diet affect, you know, Rett syndrome or any health state, right? So the idea, what I said, of feeding the gut microbiome. So what we eat feeds the microbes inside our gut, and those microbes make substances, and some of those substances are good and some of those substances are bad. And so this study showed that you know, it can really predict how clinically severe Rett syndrome was going to be affecting the patient based on a poop sample, really, right? Which is kind of interesting. So what we can look at in the future, and I think what's really promising that we've looked at in many diseases, neurological diseases, including autism spectrum. And I don't want you to think that this is a feature, you know, really exclusive to Rett syndrome. There have been studies out there that have shown that, you know, girls with Rett syndrome, their gut microbiome is very similar to, you know, kids with autism spectrum disorders. So there's a lot of, you know, a lot of different types of diseases that have actually shown very similar features, not the same kinds of microbes, but the idea being dysbiosis or shift of the microbiome. So understanding, I think in the future, you know, diet, right, is a major force, you know, of how the microbiome, of what makes up the microbiome, right? So, and the differences in macronutrient intake can, you know, what we eat can promote, you know, growth of certain good bacteria or bad bacteria. So it's, you know, all what you put in your mouth, basically, you know, other factors like reducing stress, getting out, getting vitamin D, sleep, exercise, those are important, but 90% of it is diet. So I think that's a great, thing to start looking at. And because Rett and because of anything really, because we know that the gut communicates with the brain and Rett involves neurologic function, I think it's something that we can look at. We know that diet certainly has been used or deployed in things like seizure disorders, autism spectrum. And so I think that it's something that we can and are looking at for future targets for diseases. And then, you know, really, you know, to keep your gut healthy, it's really about the diversity and the amount of fiber, and you know, what that produces. We can talk more about that, go into detail about the gut microbiome, but the idea being that it could be a potential target for treatment. They are looking at that now. As of now, they don't have there's no recommendation for probiotic or any kind of dietary treatment. But this is the kind of stuff that excites me, and I thought I would share that with you. And that is, I think that's about it for me. And I'm happy to take questions. Thanks for having me. If you have any questions, if not, we can just sit here and look at each other or not.
I had a question.
Thank you, Dr. Winderman. That I feel very well informed and process all of that. No, I mean, I think that was so helpful. Very, very clearly explained to us lay people, and also really interesting to see the things that have come up. We had a couple of sessions last year actually on gastrostomies with parent panels.
Cool.
And digestive issues, and it's really interesting to see those issues that are coming up and repeating, and then to take it to a next level of what more can we know about and what more can we be doing. Absolutely fascinating. And as someone whose daughter is just starting to develop some swallow issues, really, really valuable. So thank you hugely. A couple of questions have come in on the chat box. Abigail, are you still here, or have you had to run off to school run? I think Abigail's still on, but I know
just here for 5 minutes.
Just because you've got to run off to school run, do you want us to squeeze in we'll try and get your question?
If you think you can squeeze it in.
Do you want me to just read it out, or do you want to?
Yeah, sure. Might as well. Thank you.
Okay, let me get back to it. So Abigail has said, I'm just going to read it, but this is from Abigail. 12-year-old daughter is experiencing episodes of distress that manifest as rage and desperation for up to 5 days and nights at a time. They've tracked it back to an increase in her buspirone and wondered if this could have sedated her gut motility too much. The rage escalates over 2 to 3 days and nights, including self-harming, scratching, hitting herself. She drinks loads, and eventually after this would have a cannonball hard bowel movement. She's otherwise regular, 1 sachet of Movicol a day. Constipation hadn't before occurred, but Abigail suspects a small amount of fecal impaction, hence the periods where she was fine and then escalating. They've increased the Movicol plus Senna, and the GP has prescribed sodium picosulfate twice daily, which they haven't started yet. The sensation of gas bubbles moving through the system triggers seizures, which is currently uncontrolled by meds, and everything snowballs, as we can all relate to. They're waiting for an appointment with a pediatric gastroenterologist.
Yeah, my mom can't even say it, so you're fine.
Waiting for an appointment with one of you. But what should they be asking? Her digestion is delicate and her seizures are very linked into everything else. Eats fine orally, dysphagia assessment is fine, drinks via a straw, very mobile, sensitive to gluten and dairy, so avoids that, but eats pretty much everything else. Was that paraphrased? Okay.
That was good. Well done. It was long.
Okay. I'm going to say this much is that, I'm happy to connect offline. It seems a lot of you guys, every patient, not just your girls, but every patient is different in the way that they respond to meds and their environment, and things do change and evolve. And I think the best way probably for me to answer and discuss this would probably be offline. And I do private consultation. So I can definitely send Beth that. But I would say, in general, figuring out, coming to us with a list of medications and a list of, even a 3-day food log can be very helpful for us of everything they eat over the, 3 days can really help us give an idea and represent what long-term feeding, habits they get into. And, consistency, even taking a picture of stool can be helpful for us. And then sort of, the idea of like how symptoms, characterizing symptoms, right? So onset, duration, you've given beautifully, but sort of organizing those questions accordingly, I would say is probably very, very helpful. And again, duration, when did it start, initiation, duration, and then, I think you have all that information. Difficult to say right here, right now, but I'm happy to connect with you offline and do, a quick private consult if you want, and just go through everything with you. I mean, I do this a lot with patients. I have many patients abroad. Actually, I see a lot of patients in Israel, and I have a patient also in the UK that I see virtually as well, and happy to coordinate with your pediatric gastroenterologist in the UK. We're a very small, tight-knit community, even worldwide, there's very few of us. So,
Sure.
I do a lot of collaborative work with other gastroenterologists, and I'm open to that, and a lot of them are as well. So and I do take another approach. I do kind of take my patients off a lot of their meds, including neurologically involved patients. So let's connect offline. I'll give Beth that information.
Thank you.
Sure.
I have to go and get my son from school, so maybe Beth can forward my email address. That'd be really helpful. Thank you, because I don't imagine that we'll see a consultant anytime soon. I mean, before COVID, it took 8 months, so I really don't think it'll be till this time next year.
So I'm available. So let's chat offline, and then I'll send you a form. You can fill out everything, and then we'll have a nice longer discussion. We'll go through everything and come up with something to at least get him to a point where we can at least make it to that time.
Yeah, great. Thank you. Thanks everybody. I've got to go now, but thanks for arranging this. Cheers. Bye. Hi Beth. Bye.
I think Diane is still here, and Diane's put a question in. She says, my daughter has been losing weight slowly for months, and she also has a random cough. Could this be partial reflux?
Yes, 100%. It definitely could. Weight loss in general is a problem. So discussing this on a personal basis would probably be most helpful. But in general, when I look at weight loss, the idea is, either it's this, right? Either it's we're not getting enough in, or we're getting enough in and something's going on between mouth and anus, right? So either we're not getting enough in, which is 99% of the time the issue, but if that is appropriate, then there's an issue absorbing the nutrients, right? And that's something that needs to be further worked up. In terms of cough, a lot of depends on, when the cough happens, how frequently. There's also, asthma, cough variant asthma. It depends on, allergies. This could also be postnasal drip. So I think it would be worthwhile to connect on an individual basis. And I think, Beth, I'm just going to send you the information that you can just share out for people to be able to at least book, a quick call with me, and we can discuss, everyone's individual situation is very, very different. But certainly, yes, it could be reflux 100%. It could also be 1,000 other things. So weight loss is the biggest concern, but certainly we can connect and discuss that as well. But yeah, calories, 3-day food log is so helpful. So if you could do that before you meet with anyone, including myself, that would be ideal.
Thank you. She hasn't had any change in her diet at all, and that's why it's just a mystery. Her trousers are falling off her, and so it was just interesting to hear that. Nobody else has said that, so thank you for all your information, and I absolutely agree, we are what we eat.
Yes 100%. I would also just say that, many times, we say, oh, their diet didn't change, right? But their age and their nutritional requirements do. So just keep that in mind, as well as that as we get older, we do end up needing more calories. So that's something just to consider.
33, well. So she's finished growing. She's 33.
She is finished growing. All right.
A quick question from Minity, which ties into
I'd like to just interrupt you. Then I would say that that's important to get worked up, because that's not normal then. But yeah, okay, sorry.
I know, that's fine.
Yeah.
This Minity's question will play into something I was going to ask, just because I've seen some of your YouTube videos that are about no probiotic is good. So I've been watching those in the last few days. Minity's question is, in the past, we've used 2 probiotics and they seem to cause more pain, so they stopped. Is there a systematic way of knowing which particular prebiotic / probiotic will be useful, rather than just randomly trying different products?
Yeah, so the idea of probiotics just being introducing these, like I said, we've identified these good bacteria. And so, the industry has been born where they're like, well, we'll just pack them into a pill and throw them down and see, more of a good thing is always a good thing, kind of a thing, right? So our belief system as a society, and this is international as well, is that, they're not regulated and I wouldn't use them. They have been, they're live bacteria. They've been shown to cause infection and death, even in some cases. So I would avoid giving live bacteria through, billions of colony forming units via supplement. But I would definitely, more importantly is feeding the bacteria. So prebiotics is what the bacteria eat. Well, so more importantly, just your colon knows what to do. Your gut knows what to do. It's about feeding it the right thing so that it can function the way that it should function, rather than throwing down, new bacteria into there. Everybody needs a little bit of a different combination. But in terms of prebiotic, getting fiber in there, making sure you're getting a diverse, a wide diversity of fiber, meaning we used to just think having oatmeal in a bowl was enough, get those grams of fiber, 30 grams of fiber, right? But now we know a little bit better based on gut microbiome studies that our community of microbes in our colon, actually, they all eat a little bit of different things, right? Not everyone here likes pasta. So, we have to feed our gut microbiome a diversity of rainbow, is what I say, of fibers. So eating things of different color, different origins is important to keep those microbes healthy. So feeding what we have, trusting our body is important. We can do it without the use of supplements. But yeah, I saw you raising your hand, and but your name says Reverse Rett. So Reverse Rett, did you have a question?
Yes, it's Rachel. I thought it was a brilliant presentation as well, and also I love the way you make everything so simple for people to understand. I was really just going to ask about how people can vary up the microbiome without using any kind of probiotics or what have you, because you talked about how important it was, but we didn't really go into what kind of food, although there was a picture with the burger in. And so just to hear you say, everybody eat as much rainbow as you can. And one thing that I heard recently I thought was really interesting was, even if you go to the shop and you get a carrot that's from a different area from another carrot, things like that can add to the variety in your microbiome. So we all get into these ruts, don't we, of eating the same kinds of things all the time, but just trying to make sure you eat lots of different things. But the main point I was going to make, if I'm honest, is just that, when Amber here was little and we worried about her eating enough food, the focus was very much on just get her to eat as much as possible of anything. So she put some weight on and she got really into things like, McDonald's and things. And had I known at the time how important it was about things like the microbiome and so on, and how much diet can actually cause people to have just a better quality of life and so on, it would have been much better. So I really appreciate you stressing this message to people. Yeah. But what do people do if they have a little one that's not, because here you don't really get, if the parent requests a G-tube, that doesn't really happen here. I lived in the States and I asked for Amber to have a G-tube when she was 5 and we got one. But here you have to have met a certain threshold, and it's usually you're very desperate, you've got an NG tube for probably a year and then you get, yeah. So how do people get the, variety into people? That's one question. How do people get the variety into people who are little, and obviously they have all these texture issues? That's one thing. And then the other thing is, how do you manage microbiome in people that have the formula on when they have, like that's what all they eat?
Yeah. So I want to touch on, before I answer those two questions, the importance of what you said about microbiome makeup when it comes to different kinds of fruits and vegetables in different areas of the world. I think that makes a beautiful point, right? Everything that you eat, everything that you touch has a microbiome of its own, right? So You know, when we talk about foods that are shelf stable, they've removed that microbiome because otherwise it would rot, right? So those are things like that sit on the shelf that are okay for weeks, or even in your fridge, you know, bread that doesn't get moldy, or, you know, things that don't end up spoiling, right? They've stripped all of that microbiome, all the bacteria, any sort of, you know, live organisms away from that, and put in what we call preservatives. So you know, what I would say is eating a whole food diet, and really keeping that in mind of, like, you know, staying away from shelf stable stuff is important, just in understanding, like, you know, microbiome in general. Everything has a microbiome. And so eating anything from any different part of the world, or any kind of fruits, vegetables, anything that doesn't go bad, I would say is probably excellent, with the exception of red meat, which I'll be honest with you, and we can have these discussions, apart from patients who require a ketogenic diet to control seizures, which is a small portion of patients. The red meat has been highly associated with chronic disease, morbidity, mortality, and we can talk about that another time. So with the exception of that, which does go bad, anything that does not go bad is usually not great for you. So I would say that much. When it comes to diversifying gut microbiome, I get it all the time. My kid doesn't like vegetables. My kid doesn't like fruit. You know, what I would say is, you know, to those kids, it's a little bit different. Getting them involved, and eventually you want them to eat things. So hiding them in soups and hiding them in smoothies is not the best idea. But in a child that's, you know, more neurologically involved, smoothies, finding it, the thickening, whatever it is, you know, but blenderizing any sort of, you know, fiber source. So fruits, vegetables, you know, even beans, legumes, like cook them, blend them. And if they can take in, you know, in that way, that's great. You can even like add some water or whatever to it to thin it out, just bringing that consistency in. And I'll be honest with you, I'm one of the very few that, even with gastrostomy tubes, I do put blenderized food in there. And so I will never formula feed entirely a child. I'm not sure how it's practiced in the UK, but you know, there's no reason to give everything via, you know, a nutritional supplement. You can meet needs without that, and we can make food, whole food, to a consistency that will go through a feeding tube. So, and we can freeze it. Like, I'm happy to work with any and all of you to sort of change around diet, and not to be distressed. You know, I mean, yes, your gut microbiome develops really in your first few years of life, you know, as children, but you can reset your gut microbiome in 3 days, and consistently giving the right foods, you can continue it to keep it healthy. So it's not the end all. I didn't know about it either. I ate garbage when I was growing up, so we're all just doing our best. But yeah, happy to work with any and all of you, because I don't really have a suggestion for fully and liquid enteral nutrition. I don't do that. The only time I ever really give liquid nutrition is through the IV if they need, you know, parental, but that's a whole other subject. But yeah, there's always an opportunity for opportunities.
Wow, thank you. Does anyone else have any more questions?
I had a question.
Do you?
Yes. When are you coming back here? To make your bowels work. So Lotta gets very constipated and she's on Movicol all the time. Is having the water through her feeding tube the same as if she was drinking water when it's not going through that tract?
Yes, 100%. Yeah. It's 100%. And it's important too. Yeah, it's definitely, yes. The answer is
okay.
Yes.
Thank you.
A simple question for a change. I just had one question, which I think is quite general. Oh no, we've got somebody waving their hand. So let's start there. Vivian's got a question. Go for it, Vivian.
Wendy Brooke is 35 and she is high functioning Rett syndrome. She just doesn't talk. She can, if you say, Wendy, say hello, she'll repeat me, but only short 2 and 3 sentences. And enemas has been our way of bowel movement. But up about a year ago, Wendy Brooke has learned to put her fingers in her rectum and make herself go. and I can't catch her all the time. She'll get up during the night when I'm sleeping, and I just wonder if you've got any suggestions. I took her to a gastro, and he don't want to put her to sleep and fix everything that's hanging out, because when she comes to, she's going to start it all over again and rupture everything he fixed. I wish they could invent a toilet that when it smelled poop, it would go beep, beep, beep to get me back there to help get it assisted. I just don't know how to handle this. I can't keep toilet paper on the roll because she will roll it all off, clog the toilet up. She'll take, after she's used her fingers, and wipe it all over her clothes. And it just starts a big cycle. And I just wondered if you've ever came across this and could give any suggestions on
so I
how to control of it.
Sure. So I get that also, you know, from below and from above as well, right? So I get patients that actually will stick their fingers down their throat. And, you know, the thing to really ask yourself here is, you know, a lot of time that's reflux, right? They want to get it out, or, you know, from below also, they want to get it out. It's uncomfortable. So I would just pay attention to the consistency of the stool, probably a little bit constipated and uncomfortable. And she's smart and figured out a way to get it out, and probably very frustrated about it. And that's why she's smearing it everywhere. But, you know, again, we can connect offline, but that would be my first initial instinct. Is that's very common behavior when there's pain, you know, associated with any sort of part of the GI tract. So I would take a closer look at that, you know, rather than calling it, you know, behavioral, especially if this is a new onset symptom or sign. Yeah, I would say, and you know what, I would even say, forget taking a look. I would just start treating for constipation and see if that helps improve it at all. You know, even giving like, you know, and not medical advice, but giving like I guess Movicol is what your polyethylene glycol is called over there. But I would give, you know, a cap or two of that and see, you know, for a week or two and see if that's helpful. You know, a lot of times we learn to withhold stool too. If it's hard to poop out, you know, we're like, all right, well, I don't want to do that again. So they hold it, which makes it worse. It's a whole cycle. So it often takes a few months of giving Movicol daily. So I would just try that if I'm honest, and then see how that goes. But there's something going on. I always believe there's something going on. So happy to connect also offline and discuss if that's something that interests you and if that doesn't work. But yeah, I wouldn't recommend doing endoscopy or colonoscopy. There's absolutely no need for that. She's 35 years old and she's been perfectly fine up until now. There's no reason to suggest that she's having a motility issue at this point there.
I just asked Vivian, where are you based?
There's just so many little fishy.
Is her connection poor?
There's so many little fissures and stuff there now that I can't even see the anal. Yeah. I'm sorry, I didn't hear the question.
I was just checking where you're based.
Tennessee, United States, Tennessee.
Yeah. So probably Dr. Winderman will know more about the kind of treatments that you can access than we do, because it seems like there's quite a difference in the UK to how our girls are being treated for these problems. So probably connecting offline, you'll be able to.
Yeah, Beth, I'm going to send you a link that you can send to people to book a call with me, and then we can get everything straightened out. I know plenty of pediatric gastroenterologists in Tennessee. Actually, I trained with one in my fellowship, so that's in Tennessee. So happy to do that. We can also talk about starting Miralax, or the fissures that you're seeing are constipation. My guess is that it's constipation. So we can connect offline. I'm not leaving any of you. I'll hold hands. Now you are all my patients. So now you have me.
Thank you.
She's been on all of it and she still stays constipated. You know, now we're on Linzess and Synacot, and she's been chronic all her life, and it's just she got tired of me doing the enemas and she took it upon herself. She is very intelligent.
Yes, they are.
Dr. Ira Stein is her doctor.
Yeah, so let's connect offline, and I definitely.
Thank you.
Yeah, sure.
I'm conscious of time, but there are two more questions that have come in. Are you able to hang on for a few minutes?
I can answer more.
Okay, sorry. So Sue has said, could you just explain a bit more about malrotation?
Yeah, so malrotation is just a twisting of the intestines, and it can actually happen what we call congenital malrotation. So they're born with intestines that are not, fully, when they develop in utero or in the stomach, basically the intestines are actually turned one way, and throughout development, they actually untwist. And so the failure to untwist is what we call congenital malrotation, and that presents at birth with inability to feed, vomiting, and no stool production, obviously, because it's crossed or twisted. More commonly in older children, though, is what we see is, what we call a nidus or a point where, sort of the motility stops and, twisting starts to occur because something's stuck there, either stool. Sometimes it can happen after a virus where a lymph node's a little bit inflamed, and that becomes the point of turning. And so, kids can often, or anyone can often have these episodes of severe pain where and it'll twist and untwist and twist and untwist. And it can be so frustrating to parents who keep running into the hospital, getting these ultrasounds, and then not, and not knowing, and, keep saying, oh, it's not malrotated, it's not malrotated. But the idea with malrotation, and in fact, intussusception, or the sort of accordion in and out of the bowel, is really that it is a transient occurrence. And so catching it then is the right thing. But on the other hand, if it's not something that's happening chronically, or it doesn't stick it doesn't stay twisted, the chances are that treatment is sort of a watch and wait kind of a thing. And, what you really want to wait for is that, or look out for is that GI crisis, or, not stooling, vomiting, signs of obstruction, those kinds of things. But yeah, two different kinds of malrotation, certainly. Did I answer your question?
That helps, Sue.
Yes, thanks. That was a great help, because I have been quite confused about it. My son hasn't got Rett syndrome, though he was tested for male Rett. He has Pitt-Hopkins syndrome. Unfortunately, he's never had any constipation or any problems at all, thankfully, but an awful lot of the children do. And there have been a few recently that have been in hospital having numerous operations, and it just seems to be, I'm hearing more and more, not just in the UK, but from the States, but not enough is known about it because we're such a small population. It's not knowing really is how common it is, and therefore is it can I sort of start saying it's happening more, therefore it's something that's got to be looked at in more detail for all the kids, rather than them getting to a crisis, because sadly I do know in one country where it's being fatal.
Yeah, so keeping the things that we can control, obviously lymph node size and polyps or whatever, are very uncommon, but keeping our stool consistency soft, and regularly soft, is probably the best way to avoid that. But also just know that, like, kids in general, they're the interesting thing, and the thing that makes it difficult, obviously, to scope, is that their GI tract is not pinned to the mesentery, or like as an adult, it's actually becomes then fixed, but it's sort of like this moving tract. So until they become adults, when it's actually fixed and pinned, that possibility for malrotation is certainly there. I think you're seeing it probably more now, becoming more aware of it in the fall winter months, is when kids get these viral infections, upper respiratory tract infections. So we do see a lot more of it during that time. I wouldn't say that I've seen more than usual, but again, I think you need probably population studies, more data to say that. But anecdotally, this is the rise that I usually see in the fall, winter months. Yeah.
Well, one particular boy that's been in hospital since April. It was April that he was having like weeks and weeks of crying, and finally, fortunately, a doctor referred him to the hospital. By which time while he was actually there, he suddenly looked 9 months pregnant, and they rushed him to theatre because they thought it was going to burst otherwise. And that was, and since then he's just been there, and more going wrong, sadly. Though he does seem to, at last, he's back on the normal ward, and he seems to be improving, but he's had about 5 operations now.
Yeah, I mean, once you get to a point where perforation happens, meaning that you start having waste in your circulation, it's kids, kids, particularly when they crash pretty quickly. So paying attention to, everything means something. So I always tell my patients I'd rather know than not know. And, I could always, especially nonverbal children, we can always bring them in for an x-ray. It's not ideal, but it's certainly better than risking the idea of perforation. So everything, medicine is nuanced, it's, happy to talk more offline also. To anyone that didn't get questions asked, I'm going to send you information, Beth, so that people can book something with me so we can talk.
Thank you very much. It's been really, really useful.
Sure.
Thank you, Dr. Winderman. Dawn, you were waving at some point. Do you have a question that we can squeeze in before we let everyone go?
Hopefully just a quick question. When you're actually putting a gastrostomy in, is there, each patient has an optimal place to place it, or do you just sort of put it wherever looks best on the day?
Yeah. So I happen to use ultrasound just because, the last thing you want to do is, one of the complications that you want to avoid is obviously, puncturing the colon. So, I use ultrasound to guide it, but yeah, I would say that, we do have an optimal location. And what I do is I use the endoscope and I take a look at what part of the lining lines up best to the outer skin level. And then from there, I make the incision and place the tube. But in general, I would not place it too close to the pylorus or the entrance to the small intestine, because you end up having what we call dumping syndrome. You don't want it to be too close there. You also don't want it to be too close to the lower esophageal sphincter. You don't want to start giving them reflux. So there is an ideal and there is a measurement of where it should be placed. And of course, if your patient's starting to have symptoms or anything like that, just trying to figure out, where it's placed, when the symptoms are happening, in relation to what time, that sort of thing, we can sort of dissect and figure out if it's a tube placement issue. But yeah, yes, there is a certain ideal placement of the tube. It's never what just, happens on the day of. Everything is well thought out. Yeah.
Brilliant. Thank you.
Sure.
All right. Thank you so much. I think this, a sign of a fantastic presentation and presenter is that people want to keep asking questions. So I think everyone's found that really, really valuable. And I know that there will be a lot more views online, and you may well have a few more follow-up questions. But thank you for giving us your time today. Very much appreciated. And thank you everyone for joining us. You will get the recording link next week. And more information about our next sessions also coming to you soon. But thank you very much again.
Yeah. Put me on your email list. I'd love to be notified about other events also. It's always room to learn. So
that's fantastic. Thank you so much. Thank you, Hazel, for bringing Dr. Winderman into our lives. And have a great evening and weekend, everybody.
Enjoy. Thanks for having me.
Thank you so much. Take care.
Thank you.
Bye, everyone.
Bye.
Bye.